Good day, I am Dr. Ncete, and today I will be talking about anticoagulation in cancer patients that are at an increased risk of bleeding. Okay, so I'll start with a background on cancer-associated thrombosis. Why is it important and how is it different from the typical venous thromboembolism that we see in patients that do not have malignancy? So cancer-associated thrombosis is actually quite a common complication in patients that have malignancy. And these patients often undergo diagnostic imaging scans, for example, CT scans for staging purposes and also to assess response to treatment. And this increases the detection rate of venous thromboembolism. And this venous thromboembolism is a major cause of morbidity and mortality in these patients. And additionally, patients with cancer have a higher risk of recurrent venous thromboembolism. And more importantly, thrombosis is the leading cause of death in cancer patients, second only to the malignancy itself. So therapeutic anticoagulation then becomes very crucial, firstly to prevent thrombus progression and secondly to reduce the risk of recurrence. However, anticoagulation does come at the price of an increased risk of bleeding. So patients with malignancy require a personalized approach to choose the most appropriate type of anticoagulant therapy. And low molecular weight heparins have been the preferred anticoagulant agent for patients with cancer-associated thrombosis, and this is due to the better efficacy and similar safety profile compared with vitamin K antagonists. And there has also been new evidence that has established direct oral anticoagulants, the so-called DOACs, as an alternative for the treatment of cancer-associated thrombosis, and a minimum of about 3 to 6 months of anticoagulant therapy is currently recommended, with extension of treatment duration in those patients that have active cancer or are currently undergoing cancer treatment, as this patient population has a higher risk of recurrent venous thromboembolism. I mentioned previously that patients with cancer often have incidentally detected venous thromboembolisms. So are these important? And should they be treated the same as a patient that is, for example, symptomatic? What I found interesting is that up to 50% of all pulmonary embolus in cancer patients are actually detected incidentally, and these patients should be treated the same as those who are symptomatic. And there are studies to suggest that the clinical outcomes are similar in both symptomatic and asymptomatic patients that have a pulmonary embolus. And by treating this patient with therapeutic anticoagulation for at least 3 months, we are reducing both the mortality and the venous thromboembolism recurrence. Okay, so what are the risk factors for cancer-associated venous thromboembolism? So the first category I'll discuss are patient-related factors, which are actually the same as all other patients. So we know advanced age, comorbidities, immobilization or hospitalization, and a history of a previous venous thromboembolism. And then those risk factors that are related to the tumor, which will depend on the type of tumor that the patient has, and those that have a very high risk of venous thromboembolism would be gastric, pancreas, and brain tumor, and those that have high risk would be lung, and more importantly for us, hematologic, and then renal, gynae, and bladder. And it will also depend on the stage of the cancer. More advanced, having a very high risk of venous thromboembolism and also localized tumor compression. And thirdly, treatment-related factors. So that would be chemotherapy, surgery, again, increased with abdominal pelvic surgery, radiotherapy, and central venous catheters. Okay, so what is the current management of cancer-associated thrombosis and how is it different from management of venous thromboembolism in other patients that do not have cancer. So initial anticoagulation may involve a low molecular weight heparin, unfractionated heparin, direct oral anticoagulants, particularly the anti-10A inhibitors, so that would be rivaroxaban or edoxaban. And among the parenteral agents, a low molecular weight heparin is preferred over unfractionated heparin in the absence of severe renal impairment, so creatinine clearance of less than 30. Although unfractionated heparin is not commonly used, it does have some advantages. It can be used in severe renal impairment. It has a shorter half-life, so if a patient complicates and bleeds, it will be out of the system within an hour and can be fully reversed with protamine sulfate. However, vitamin K antagonists do remain a treatment option for patients that don't have access or have contraindications to a DOAC or a low molecular weight heparin, and they are cheaper and may be globally more easily accessible than the other drugs I've mentioned. Whatever treatment is administered to patients has to be backed up by evidence. So what is the evidence for a low molecular weight heparin versus a vitamin K antagonist in patients that have cancer and acute venous thromboembolism? So the evidence is actually obtained from the CLOT and the CATCH trials. There are other trials, but these are some of the largest trials that were done. And these compared two low molecular weight heparins. So the CLOT trial used dalteparin and the CATCH trial used tinzaparin and compared it to a vitamin K antagonist. What they found was that there were lower rates of recurrent venous thromboembolism at 6 months and a similar risk of bleeding events in patients that were treated with a low molecular weight heparin. So what this means is that low molecular weight heparins are more effective than vitamin K antagonists without any increase in bleeding complications. Low molecular weight heparins have been compared to DOACs, and currently anticoagulation with either Edoxaban or rivaroxaban has been incorporated in the updated guidelines for management of cancer-associated thrombosis as alternatives to low molecular weight heparin. And the advantage of using DOACs is that they are orally administered and have an easy standardized dosing, which might enhance patient compliance. There's still advantages to using low molecular weight heparin because there is extensive experience in the management of cancer-associated thrombosis, and they can also be used in patients that have contraindications to DOACs. What they found in these studies is that DOACs are non-inferior to low molecular weight heparins in terms of overall safety and efficacy. And there's no data currently comparing a direct thrombin inhibitor, dabigatran, with low molecular weight heparin for the management of this subpopulation. Okay, so I thought I should look at the evidence for each of the DOACs that are currently used for the treatment of cancer-associated thrombosis quickly. So I'll start with Edoxaban. So the Hokusai VTE cancer trial was a non-inferiority trial that compared Edoxaban to anticoagulation therapy with dalteparin for a treatment duration of approximately 6 to 12 months. So Edoxaban was given at 60 milligram once daily after at least 5 days of low molecular weight heparin, and dalteparin was given at 200 international units per kilogram once daily, followed by 150 international units per kilogram once daily after the first month. So the primary outcome was a composite of recurrent VTE and major bleeding events at 12 months, and these did not differ in the two groups. So patients treated with Edoxaban additionally had fewer venous thromboembolism events, but rates of major bleeding were higher. So there was an excess of gastrointestinal bleeding in patients that had gastrointestinal malignancy, those listed there. There was a subgroup analysis that was done of the major bleeding events in this trial that suggested that in addition to the gastrointestinal malignancy, there are other features associated with a higher risk of major bleeding. So that would be your urothelial cancer, renal impairment, thrombocytopenia, intracranial malignancy, if there's metastatic cancer, recent surgery, or the use of antiplatelet agents. So what about rivaroxaban? In SELECT-D pilot study, rivaroxaban was compared with dalteparin for the treatment of acute cancer-associated thrombosis, and it was given at a dose of about 15 milligrams twice daily for the first 3 weeks. This was followed by 20 milligrams once daily. And the 6-month cumulative incidence of recurrent VTE was lower in patients that were treated with rivaroxaban, and the incidence of major bleeding and clinically relevant non-major bleeding was higher. And again, similar to Edoxaban, the bleeding comprised mostly of upper gastrointestinal, urothelial, gastroesophageal, and colorectal cancer. And patients with these cancers were subsequently excluded from participating in the study. The last drug I want to discuss is Apixaban. So the ADAM VTE trial compared Apixaban to dalteparin, and no patients had the primary outcome of major bleeding in the DOAC arm, which is in contrast to the other 2 DOACs that I've already discussed. And recurrent VTE rates were significantly lower in the DOAC arm, and the frequency of clinically relevant non-major bleeding was similar in both groups. And there's another study which was also a non-inferiority trial that compared the same drugs, and it showed similar results. So this drug is really promising, particularly for those patients that have GIT malignancies. So what are the things to consider prior to prescribing DOACs in patients that have cancer-associated thrombosis? First, and the most important, is patient's preference. That should be taken into account in your decision as to which anticoagulant the patient is going to be on. And secondly, drug-drug interactions, as systemic cancer-related therapies may interfere with DOACs. So potent inhibitors or inducers of P-glycoprotein and cytochrome P450 can influence metabolization and potentially alter the efficacy and the safety profiles. A low molecular weight heparin would therefore be preferred, or reduced dose of Edoxaban, such as 30 milligrams once daily. And thirdly, bleeding risk assessment is very important. However, there's no tool currently available in this patient population to predict the risk of bleeding. The evidence so far shows that there's an increased risk of bleeding with GIT or genitourinary malignancy. Just to expand on the drug-drug interactions, polypharmacy is common in patients with cancer who are often treated with multiple anti-cancer and supportive therapies. It's therefore important to evaluate the potential for drug-drug interactions in these patients when selecting the appropriate anticoagulant therapy. All DOACs are substrates of pre-glycoprotein, and Apixaban and rivaroxaban are also substrates of the CYP3A4. So therapies that affect these 2 pathways have the potential to interact with DOACs. So other important inhibitors of the pathway are your antifungals, ketoconazole, itraconazole, antiretroviral treatments, lopinavir with ritonavir, etc., which cause significant increases in rivaroxaban exposure particularly, and may therefore increase the bleeding risk. So thrombocytopenia complicates the treatment of cancer-associated thrombosis. And despite the increased risk of bleeding in cancer and thrombocytopenia, the risk of recurrent VTE is actually not reduced. So patients with cancer, acute venous thromboembolism, and platelet count of more than 50 should be treated with a full dose of anticoagulation with either low molecular weight heparin or direct oral anticoagulants. There's no clear guidance on use of DOACs in patients that have severe thrombocytopenia, that will be less than 50. So consider switching DOACs to a low molecular weight heparin when the platelet counts drop below 50. So those patients with platelet counts between 25 and 50, the most important question one should ask is, what is the risk of VTE progression? If there's high risk VTE features, that would be if the VTE is symptomatic, there's a proximal PE and DVT, it's within the acute phase of the VTE, that is less than 30 days since diagnosis, then a full dose anticoagulation with either a low molecular weight heparin or unfractionated heparin in combination with platelet transfusion to keep the platelet count at least above 40 to 50 would therefore be indicated. Or if there's low risk of VTE progression, that will be a distal DVT, incidental subsegmental PE, or it's within the subacute phase of the VTE, more than 30 days since diagnosis, then a reduced or prophylactic dose of low molecular weight heparin would be indicated. So reduced is like 50% of the dose. And anticoagulation should be withheld temporarily for low-risk patients with platelet counts below 25. Okay, so what about renal impairment? So in general, anticoagulation for prevention or treatment of VTE in patients with cancer does not require specific adjustment if there is mild renal insufficiency. One particular clinical challenge, though, are patients with severe renal dysfunction because low molecular weight heparins and DOACs depend on at least some degree of renal clearance. So in this case, the use of unfractionated heparin is suggested for a creatinine clearance of less than 30 or low molecular weight heparin that is adjusted to anti-10A levels. What about renal impairment and low molecular weight heparin? So studies have noted the inverse relationship between the estimated creatinine clearance and low molecular weight heparin anti-10A concentrations that might be dose dependent. So low molecular weight heparin accumulation can increase the risk of major bleeding. Therefore, its benefits must be carefully weighed against potential complications in this subset of patients. So a reduced dose of enoxaparin in patients that have severe renal impairment has been suggested to lead to fewer major bleeding events compared with standard doses. Okay, so these are the dosing recommendations according to creatinine clearance, and I'm only going to discuss the two that may be more accessible than the others. Okay, so the first one is enoxaparin, and if the creatinine clearance is less than 15 or the patient is on dialysis, a reduced dose is recommended, so 1 milligram per kilogram per day. And that's similar to if the creatinine clearance is between 15 and 29. So you can use the same dose up to a creatinine clearance of between less than 15 to 29. And once the creatinine clearance is between 30, actually to more than 50 to normal, the normal dose can be used. And for rivaroxaban, it's not recommended if the patient is on dialysis or the creatinine clearance is less than 15. And from about a creatinine clearance of 15, a dose of 15 milligrams twice daily for 3 weeks, and then 20 milligrams once daily can be used. But if the creatinine clearance is between 15 and 29, this dose must be used with caution due to the potentially higher bleeding risks. And between a creatinine clearance of 30 to more than 50, it's the same dose. Okay, so what about gastrointestinal tract or genitourinary malignancy? So in patients that have these type of cancers or nephrostomy tubes or active gastrointestinal mucosal abnormalities such as peptic ulcer disease, do not use DOACs as the first-line treatment. Although Apixaban appears to be associated with a similar risk of bleeding compared with dalteparin, guidelines thus far have been cautious about recommending this drug in these patients until there's more experience available. Moving on to hepatic impairment. So patients that have functional hepatic impairment may have reduced ability to metabolize DOACs, all of which are at least partially metabolized by cytochrome P450 enzymes. And those patients that have significant liver disease are therefore considered to be at higher risk of bleeding when they're treated with these drugs and were excluded from clinical trials. So for these reasons, none of the DOACs are recommended for use in patients that meet the criteria for Child-Pugh Class C, so that will be more severe hepatic impairment. And rivaroxaban is contraindicated in patients with hepatic disease, including more moderate hepatic impairment, such as Class B and C, that is associated with coagulopathy and having clinically relevant bleeding risk. Apixaban should be used with caution in patients that have mild or moderate hepatic impairment, so class A or B. So with Edoxaban, patients with mild or moderate hepatic impairment, they showed comparable pharmacokinetics and pharmacodynamics to healthy controls, but I think one should wait for more evidence before prescribing this drug in patients that have hepatic impairment. And I've also included a table there with the Child-Pugh classification just for reference. So what about the use of antiplatelet agents? So even at low doses, aspirin is known to increase the risk of upper GIT bleeds, a risk which appears to be increased when it is used in conjunction with oral anticoagulants. And this was confirmed by a subgroup analysis of data from the Hokusai VTE cancer trial, the trial that I've previously discussed, that compared Edoxaban, which showed an increase in the risk of major bleeding in DOAC-treated patients that are on concomitant antiplatelet therapy. So the guidelines recommend that the indication for antiplatelet agents must be reassessed and discontinuation should be considered if there's no strong indication in those patients that are newly diagnosed with cancer-associated thrombosis. What about patients with low body weight? I've mentioned that some of the drugs, particularly DOACs, have standard dosing. I mean, does that then increase the risk of bleeding in patients that have low body weight? There's actually very limited evidence available, but an agent with weight adjustable dosing, such as Edoxaban or a low molecular weight heparin, should be considered in patients that weigh less than 50 kilograms. Next, I want to discuss abnormal uterine bleeding. It's a common but underreported complication of anticoagulation and is thought to occur in up to 70% of women that are of reproductive age. And the risk of anticoagulant-related abnormal uterine bleeding varies by DOAC. So with Apixaban and Edoxaban having a statistically similar risk to vitamin K antagonist, and Edoxaban appears to double the risk compared to vitamin K antagonists. Estimates of the risk of abnormal uterine bleeding with low molecular weight heparin monotherapy are actually not available. However, despite this lack of evidence for low molecular weight heparin, women that experience abnormal uterine bleeding while they're on a DOAC, then they should be changed to low molecular weight heparin according to the current recommendation. So what about intracranial lesions, such as primary brain tumor or brain metastasis? So anticoagulation should be offered as it is for other patients with cancer, although uncertainty remains as to the choice of agent and the patients that are most likely to benefit. Some studies have shown that intracranial malignancy increases the risk of bleeding regardless of the type of anticoagulation. So what is the role of retrievable inferior vena cava filters? They might be considered in very selected cases until anticoagulation can safely be initiated. So patients with acute venous thromboembolism and absolute contraindications for anticoagulation. These will be those patients that are actively bleeding and those that have severe prolonged transfusion-resistant thrombocytopenia. And the insertion of an IVC filter should not be offered to patients with established or chronic thrombosis, so VTE diagnosis that is more than 4 weeks, or to patients that have a temporary contraindication to anticoagulation. And there is no role for IVC filters for primary prevention of venous thromboembolism. So far, I've only mentioned therapeutic anticoagulation and did not really discuss thromboprophylaxis. But with this one slide, I thought I should quickly discuss the role of mechanical prophylaxis in patients that have cancer. So in cases of contraindication to anticoagulation, mechanical prophylaxis is recommended and results from a retrospective study of patients that had undergone abdominal surgery for gynecological cancers and received pneumatic compression showed that the incidence of pulmonary embolus in patients that have cancer was increased compared with benign disease. So it should therefore not be relied on as the sole method of venous thromboembolism prophylaxis in patients that have cancer. And mechanical prophylaxis should not be used in patients that have an acute deep venous thrombosis. The main advantages of using a direct oral anticoagulant is that firstly, there's a standard dose, and secondly, they do not require monitoring. So when should you measure DOACs then? So testing is increasingly performed prior to invasive procedures, during acute hemorrhage, at the time of a thrombotic event if there is suspected anticoagulation failure, in order to assess adherence, as well as if DOAC levels are suspected to be out of the expected range, such as in patients that have renal dysfunction, those at extremes of body weight, or if there's malabsorption. And the optimal laboratory method to measure a DOAC will depend on whether the tests are used for qualitative or quantitative purpose and the required turnaround time for the results. The most accurate means of assessing DOAC exposure is by measuring the concentration using mass spectrometry, drug-calibrated clot-based or chromogenic method. And due to its high degree of specificity, sensitivity, and reproducibility, mass spectrometry is considered the gold standard method. And drug-calibrated chromogenic anti-10A assays are more accessible in my setting. So how do we monitor patients on low molecular weight heparin? Anticoagulant activity is measured using an anti-10A activity assay. Anti-10A measurement is especially indicated in patients that are pregnant, have renal dysfunction, and in excessively obese patients in whom large doses are required. A 5 ml sample of citrated blood that is taken 3 to 4 hours after a low molecular weight dose is required for this assay, and these are the reference ranges for my laboratory. Although warfarin is not recommended for treatment of cancer-associated thrombosis, it is still being used for this indication. And initially, patients should be started on Edoxaban 1 milligram per kilogram subcut 12 hourly, given for at least 5 days. Warfarin should be started at a dose of 5 milligram orally from day 2. And the INR should be measured 2 to 3 days after starting warfarin, and then daily with dose adjustments to achieve a therapeutic range of 2 to 3. Low molecular weight heparin can be discontinued once the INR is in the therapeutic range. And once stable, the INR should be monitored every 1 to 4 weeks, and patients on a chronic stable dose should be tested every 4 weeks. And those patients with an unstable dose response will require more frequent monitoring. And more frequent monitoring is also indicated when there's a change in medication, intercurrent illness, and in the pre- and post-operative periods. I thought I should end the presentation with this treatment algorithm that I often refer to. Okay, starting with the platelet count. Is there a thrombocytopenia where the platelet count is less than 50? So I'll start on the right. If there is a platelet count of less than 50, the next question to ask is, what is the risk of VTE progression? If that risk is high, then that patient will require a platelet transfusion and full dose anticoagulation. And the two preferred anticoagulants are low molecular weight heparin or unfractionated heparin. So the patient has a high risk of VTE progression. Despite the thrombocytopenia, you have to anticoagulate, but transfuse platelets to make sure at least there's a decent platelet count above 40 to 50. Okay. So on the other end, on the right, if the risk of VTE progression is low, the next question to ask is there severe thrombocytopenia and the platelet count is less than 25? If yes, there's a low risk of VTE progression and the patient a very high risk of bleeding, you can hold off anticoagulation. But if there's a thrombocytopenia but still a decent platelet count, you can give a reduced dose of anticoagulation, so 50% of the dose, or a prophylactic dose, again, of a low molecular weight heparin or unfractionated heparin. Okay, so moving on to the left now. If there's a decent platelet count, although there may be thrombocytopenia, the platelet count is more than 50. So the next questions to ask is there genitourinary or gastrointestinal tract malignancy? Okay. Are there drug-drug interactions with DOACs? And I've also mentioned patient preference because they will be taking these drugs. Okay. If, for example, there's no GIT malignancy, no drug-drug interactions, then a direct oral anticoagulant can safely be used. But if there's any of these things, then a low molecular weight heparin is preferred. But if both these drugs are not available, I mean the patient needs anticoagulation, and vitamin K antagonists can be used. Lastly, the aim of therapeutic anticoagulation is to reduce the risk of venous thromboembolism recurrence without necessarily increasing the risk of bleeding. So it's about finding that balance. Thank you for listening, and I hope that everyone learns at least one thing from this presentation.